So this is called Looks Can Be Deceiving, Obesity and Chronic Care. And like I said, I am Elizabeth Hanna and I am a nurse practitioner and I'm dual certified in acute care as well as psychiatric mental health. And obesity affects more than 40% of American adults. It's also a risk factor for a lot of other chronic diseases and reduces life expectancy by between 5 and 20 years. And it costs our healthcare system over $173 billion annually. And yet it is considered by many, including health professionals, be a cosmetic issue and insurers as well. And this is because it's perceived that a lot of the reason people have obesity or drive a lot of our behaviors. And of course, issues, you don't have sleep apnea, you don't have hypertension, high blood pressure, you don't have high cholesterol, you don't have diabetes, but there's a 1 in 3, 1 in 2 chance that you will. Is that because you're in a bigger body? Maybe. Or is that just what's happening with all Americans and we don't know because we're not really looking at people who aren't obese? A lot of people get diabetes. Metabolism by doing that, and they end up with a lot of the diseases that we sort of associate with obesity. And again, like I said, it depends on where you store this. So let's go back into that fat is stored. Like I said, kind of storing it on your hips and backside is one thing, but it's also that subcutaneous versus visceral. Some people kind of have that real truncal fat where it's sort of in and around the organs. That's not great. And that fat is going to function in a different way, and it's going to create more sort of negative metabolic hormone that was my dad gave me the high blood pressure. But genetic factors are huge. And of course, inflammatory status. That's the one thing I will say about fat tissue, white fat tissue, is not only estrogenetic, which does create its own issues, it is an inflammatory tissue as well. And so if you're prone to migraines and you're carrying extra weight, it might be that that's increasing your migraines because it can actually transfer across the blood-brain barrier and get into your brain. Um, and it does increase inflammation, which is why I think a lot of times, even though it makes me a little bit crazy, people will come in and they're like, my doc sent me to lose weight because I have XYZ. And it could be anything from MS to rheumatoid arthritis. And the person might not really be that heavy. And I'm like, I don't really think you losing weight is going to make that big a difference. But I think it's kind of that thinking about the inflammatory status that's what's making the docs say these things. So clinical implications, like I said, BMI alone doesn't tell the whole story. And again, looking at our muscly man here, he was one of the Mr. Olympias, by the way, I can't remember his name. His BMI is very heavy, but as you can see, I would guess that his body fat percentage in that picture is probably around the 3% mark. There's no fat on him. And you really need to assess someone's metabolic health, not their weight. And that goes for thin people, that goes for heavy people, that goes for medium weight people. The treatment should really target the underlying metabolism. And again, like I said, insurance doesn't like to pay for that for a lot of different groups. Of course, there is a catch, like we said before, metabolically healthy obesity is sometimes temporary. Again, that 30% will convert. And it does present a really good opportunity for intervention for people. However, insurance companies are stinkers. So now what? What do we do with all of this information? We got to move beyond the eat less, move more, and start to reframe our treatment. We need to look at a medical approach to a medical problem, treat the system, not just the symptom. So not just say, well, you gotta lose weight, that's the problem. No, like we gotta figure out what's going on. Metabolic medicine first, address the insulin resistance with medications, treat PCOS with appropriate hormonal interventions, optimize thyroid function, and manage sleep disorders. And we'll talk a little bit more about OSA. And really by doing that, if we get that right, hopefully a person will lose weight as a bonus side effect. Hopefully, because who doesn't want to lose weight? Like we just said, we live in this really shallow society. People don't get raises because they're heavy set. It is what it is. Who doesn't want to take an airplane and be more comfortable? No value judgment on that whatsoever. But really, losing weight shouldn't be the goal. It should be a happy side effect because the weight gain really is an unhappy side effect of a metabolic disturbance, if you can see what I'm saying. And then, of course, if we do all those things and people still don't lose weight and they've got a BMI that's appropriate, like 35 plus, then at that point we need to start thinking about other things like surgery. So one of the things that we have is GLP-1s. And we will talk about those, I believe, next. Oh no, we're going to talk not about GLP-1. Talk about obesity medications other than GLP. So these are kind of my older ones. Really, in the past, our drugs focused on neurotransmitters. So neurotransmitters, are things that we kind of associate with being in our brain, even though that's a simplistic way of looking at it. But in particular, the medications targeted dopamine and norepinephrine. So we had drugs like, and we still have them, phentermine, Wellbutrin, Vyvanse, things that work on the hedonic pathways like topiramate and naltrexone. And you can combine these drugs. You can do topiramate and phentermine. That makes something called casemia. Wellbutrin and naltrexone makes Contrave. Vyvanse is the only FDA-approved drug for binge eating disorder. So these work by increasing dopamine and norepinephrine, kind of working on the premise that there's some sort of addictive-like behavior going on with obesity. And after everything that we've just talked about, I hope that you can see that that is definitely not going to address everything. If it's metabolically driven, it is not going to be 100% likely driven by addictive behaviors. It's just that we had medications for that, and so that's what we used. That being said, with addictive behaviors, you can take that first cigarette because peer pressure, but at a certain point, the addiction will take over. And that can definitely happen with food for some people. There can be a component to it that does feel like and look like, and for all intents and purposes, act like an addiction. And so these medications can be helpful, but do keep in mind they're only going to be addressing that section of what's driving the obesity. And it's very rare in my experience and, globally, that somebody is obese purely because of an addictive like obsessive behavior. Not entirely, but that's more or less the case. So it's really important to consider medications that are also not going to make obesity worse. And a lot of times it takes multiple agents to target appropriate pathways for individuals. So getting something for the metabolism, getting that under control, and then once that kind of what we call food noise is left over, where they're like, I'm not hungry, and yet I still am eating this thing, or I'm still doing this behavior. And it's like, okay, right there, now we've targeted. Now we're able to see the kind of addictive like behavior that might be going on. And this isn't a presentation on addiction, so I won't go super into that, but just kind of keep that in mind that, we've got hunger, driven by the belly sort of, and then we've got our head hunger that's just all inside of our head, and maybe attribute like 80-20. This is, again, I'm being overly simplistic, but it's kind of a very complicated and controversial subject that isn't very well understood. Now we have GLPs. I was joking with a patient today and I said, I used to give these talks all the time, and I would always say, now there's no one magic bullet, there's no miracle drug. And then the GLPs came out, and I kind of feel like they are a little bit of a miracle drug. These are real game changers. We haven't had anything like this on the market ever. We haven't had a breakthrough like this in decades. They've been wonderful, and they're called GLP-1 receptor agonists, like semaglutide and tirzepatide. There are name brands: Ozempic, Zepbound, Wegovy. Just a little bit of vernacular because I find a lot of my patients get confused. Semaglutide and tirzepatide are generics. So when you go and you get Advil, you're getting ibuprofen. When you get Tylenol, you're getting paracetamol, or acetaminophen, they call it here. That's this generic name, right? And then in the world of diabetes and obesity, these manufacturers of these drugs have done trials with them first for diabetes and released them under a trade name specifically for diabetes that indicated this has an FDA use for diabetes. And those names were Ozempic and Mounjaro. And then they went through trials and got approval from the FDA for weight loss. And those drugs they named Zepbound and Wegovy. And now, as they continue to get more FDA approval for different conditions, for example, Wegovy got approved for cardiac issues. So if someone has a heart attack and you put them on this, even if they don't have diabetes, their likelihood of developing another heart attack decreases. Zepbound was approved for obstructive sleep apnea and reducing it. They aren't going to change. So there's not going to be like 59 names for every single thing. They just divided it into these two categories, diabetes and obesity. And there you go. You get about 15 to 20% of weight loss in clinical trials. And it's one of the few cases where, you know, we're given a lot of promises in clinical trials, but actually I feel like in practice we see a little bit better results than what's shown in the clinical trials, which is kind of interesting. And I think that has to do with the fact that in the clinical trials, they were like, you have this dose for 4 weeks, you have this next dose for 4 weeks, you have this, whatever's going on, they've ramped you up no matter what. Whereas in practice, I go very low and slow with people to find that optimal dose. I might not have somebody on the top dose unless I have to. I don't want people to have the side effects. And so as a result, we're able to optimize the treatment a little bit better. I don't know, but I see a lot of really good results. It improves blood sugar, blood pressure, and cardiovascular outcomes. Like I said, semaglutide has an FDA approval for post cardiac arrest. And it also works on your brain appetite centers. So these hormones in your gut, GLP, and also something called GIP that tirzepatide works on, they go into your hypothalamus and they say, yo, we're done eating. And what's funny is these hormones, they last in your body naturally. Your body makes them. These drugs just go and block up the receptors so those hormones hang around longer. They only last like a minute or two in your body naturally. So for a long time, they were like, there's no way that this would ever make a useful drug. You'd have to walk around with like an IV pole with a constant drip of this stuff going into your bloodstream because it only has a half-life of a minute and a half or so. And so it was pretty incredible when they figured out how they could make these drugs not only last in your body, but last, up to, I mean, when you get an injection, it's really in your body for 29 days, even though it starts to peak around 5 days. It's about its half-life. So pretty wild. And I'm a big fan of doing multiple pathways. So if somebody is snacking on certain days, even with these kinds of drugs, we might think about doing phentermine if appropriate. And these are really more effective than lifestyle alone, by far. In the past, I felt like the drugs that I had, like the ones on the slide before, what we were doing was just trying to make things a little bit less miserable for people to eat less and move more, you know. But now, really, these drugs are addressing the metabolic dysfunction that is driving the weight gain in the first place. So it's been really tremendous. And then there's surgery. Surgery still remains the most durable, effective way to lose weight and keep it off. With the GLPs, they really are intended to be lifelong medications. Because just like if you come off a high blood pressure medication, your blood pressure is going to go back off. If you take your foot off the gas with your metabolic dysfunction, it's going to come back. We're not fundamentally changing your metabolism. Surgery, we are fundamentally changing your metabolism. We are changing the way food goes through your system, and that changes the way your system releases the hormones we just talked about, as well as a whole multitude of other hormones that impact the way you crave food, digest food, and store fat, and also the speed of your metabolism. So surgery really is quite incredible. So if you're somebody that has a BMI of 35 plus, sleep apnea, high blood pressure, hyperlipidemia, even heartburn, the various things, surgery really is something that should still be on the table for people. These medications have not replaced surgery, but they can be used with it in a great way. And I feel like there's this idea that it's a real either or situation, and it is not. These medications have made life for my post-op people and even pre-op people so much better. And again, like I won't go into details, but it's been really great. It's making it easier to make sure that surgery does last the lifetime of that person. It's also made it so that people don't have to just sit around while they wait for approval, which can take months and months. and feel like I'm not doing anything for my health. It's just such a disheartening feeling. Now we can put them on these medications. They're losing weight, getting ready for surgery. They're a healthier candidate by the time they get to the surgery table. And they come out and they actually lose more weight, and we still don't really know why. So they do better. The surgery is not a cosmetic surgery. Again, some insurance companies want to consider it that. It is really a metabolic surgery. It's not weight loss surgery. We call it that sometimes. We probably should not. We should call it metabolic surgery. It is a surgery that mechanically changes your metabolism. Also, sometimes HR doesn't get that. You might need to go and tell them, hey, you need to opt in for bariatric surgery because your HR might just be opting out of that benefit. And it is the most effective long-term treatment and the most cost-effective. When you consider that these GLPs, if you are getting it covered by insurance, which is becoming increasingly rare, but if you were to pay out of pocket $1,200 a month, we're talking about getting a sleeve starting at like $12,000 outpatient if you're an appropriate candidate. So by the time you buy a year's worth of GLPs, that pays for a sleeve. So it still is very cost effective. Again, it's not cosmetic. There's this idea it won't last. It really is the most durable solution. A lot of times people go, well, I know someone and they've regained. And it's like, okay, you know someone who regained, but I guarantee you know 5 other people who didn't tell you they got it done and they lost the weight. Almost everybody that you see in the media who lost a lot of weight and kept it off, they had surgery. It's almost like plastic surgery in the 90s when everybody come out and their face looked like that. And they're like, I just got a nap. I went home and I got some rest. And it's like, no, you didn't. You got a facelift. And I always felt bad for those plastic surgeons that were like, you're a liar. And I know Hollywood has a lot of bariatric surgeons. They're probably like, that's not true. It only works because you can't eat as much. That's a big misconception. That's not true. It actually acts on your hormones just like these medications do. Like I said, it's a metabolic surgery. And medications work just as well is a misconception. That's really not true. Surgery really still remains the only cure for diabetes type 2. And people come off their hypertension medications, their CPAP, within weeks of having the surgery. They haven't even lost weight and they're off of their hypertension meds. It's pretty amazing. And that has to do with how it's changed your metabolism. And again, saying that the obesity is a symptom, hypertension really is a metabolic disease. It's not a result of obesity. Um, and when I do put people on medications, and if somebody says, well, my big goal is I want to come off my meds, I have to tell them, studies show that we're just going to be adding this med to your list of meds. The likelihood of you being able to come off of a medication is diminishingly small. Very few people get to come off of meds because they're adding one of my meds to their list. They might feel better. It might optimize some of their meds, but the likelihood of them coming off meds is really small. The likelihood of coming off of meds post-op is incredibly high. You're going to be coming off meds. So again, like it's not really an either or. It's an integrated approach. That's what we try to take. And so we like to look at somebody and do a metabolic assessment. That might involve kind of a comprehensive hormone panel. And I'm not talking about labs necessarily, but more kind of looking at the person. What are their symptoms? And that can give us a clue as to what's going on metabolically with somebody. A sleep studies can tell us a lot about people. Sleep drives your hunger, but it also can make it hard to lose weight. Sometimes it's useful to look at inflammatory markers. I don't often do it, but every once in a while I do. But one thing that I do love doing with people is a body composition analysis. We have a body comp machine, and it can really help us know exactly how much muscle, exactly how much fat we're dealing with, and then set some more specific targets. Because sometimes people come in and they're like, I want to lose 150 pounds. And then you do a body comp on them, and it's like, you only have 70 pounds of fat tissue. Like if you lose 150 pounds, you're going to lose a bunch of muscle with that too. Target the root causes, so treat insulin resistance, address hormone imbalances, and of course, optimize sleep and stress. People always forget about sleep and stress. They're so important. Um, Stress causes cortisol to increase. That is a weight gaining hormone. And of course, nutritional counseling, not dieting. I had somebody today that was like, I don't want to go to a dietitian and be told what to eat. And I'm like, that's not what our dietitians do. They really have this holistic approach. They look at what you do eat, how you eat, and try to come up with a way that's going to work for you and optimize how you eat. And then we escalate based on response. So we add anti-obesity medications, consider surgery, and of course, long-term metabolic monitoring because it is, as I've said, a chronic issue. So metabolically healthy and unhealthy individuals. Like I said, all these things, obesity is not created equal. Some people are metabolically healthy. So if you're going to take away one thing, know that not everybody with obesity is unhealthy. Some people are healthy. Some of those people will remain healthy till the day they die. Some of them might not. And also, some lean people are metabolically unhealthy. So I really want you to take that one message away with you, that it's not about this person's fat, therefore they have diabetes. They're going to die. That's not what's going on at all. And you really need to look at the metabolism itself. So again, all of those things. Take that with you. Okay, so let's look at a few things. Let's consider Janie. I made the worst names, but this is a pre-diabetic menopausal executive, so busy, 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 lots of stress. 53-year-old woman, insulin resistance, pre-diabetic. That's how we know they're insulin resistant, because their A1C is a little bit higher, and she has sleep apnea. Does she use her CPAP? I don't know. Probably not. They're hateful. Had multiple diet failures, lost weight, regained, but then feels like a personal failure when that happens. So, we'll say she does use a CPAP. She also is on metformin, and she wants to try Zepbound. So we'll do this sometimes where someone will already be on metformin, and maybe I'll add something like a GLP. Maybe I'll add the GLP, and this is one case where they might come off the medication. I might say, let's take you off metformin, especially if they aren't tolerating it. But a typical sort of response for someone like this might be actually something like 38 pounds lost. Their sleep apnea is resolved because they're on that Zepbound, so they can get rid of the CPAP, and their pre-diabetes is reversed. It's much easier to reverse pre-diabetes than it is diabetes. The reality is, if a person only has pre-diabetes, they're not going to get Zepbound covered for that. If they have obesity, it's a coin toss as to whether they're going to get it covered or not. And it's a coin toss or it's a multi whatever sided die where most of them are saying no. And really what we're going to try to get it approved on is that sleep apnea. And chances are they're going to need to go to their pulmonologist, not me, to get that prescription. But I'll work with pulmonologists. Then we got Jimmy, a 42-year-old man, BMI 42, and has type 2 diabetes. They have been on 10 years of diabetes medication, and they've just progressively gained weight. A lot of diabetes medications are not going to make you lose weight. Some of them, especially if you start to add insulin, can even contribute to weight gain. So it's really not uncommon for people to kind of still see this progression of weight, progression of diabetes. It's never quite under control. It's really hard for people with diabetes to lose weight. When I put people on something like a GLP and they have diabetes, I tend to need to go to the higher doses, and they never lose as much weight as my people who don't have it. So they decided to do bariatric surgery plus metabolic management, and they've managed to not only lose 80 pounds, their diabetes is in remission, and they are actually off all of their medications. Sleep apnea, I told you, I talked about it. Sleep apnea is interesting because it disrupts hormones that control hunger, which is just crazy. It can also be this kind of secret cause of hidden hypertension. I saw a guy on the neuro ICU once, and he had a stroke, and he was younger. He was like 42, which I think at the time was how old I was. So I was like, whoa, what? And all that he had, his only risk factor for his stroke was he had sleep apnea, which caused his blood pressure to go skyrocketing, and then he had a stroke, and he was okay, by the way, just so you know. He made it off the ICU, but it was still like terrifying. It also helps create this insulin resistant situation, and it is one of the things that when you start to lose weight, it often improves. And it's kind of interesting. I think that we think it's because you've got kind of a big belly and it's pushing against your lungs, so it's suffocating you. They've actually had studies that show that you start to lose weight around your neck, your soft palate, and your tongue, and that actually causes you to stop snoring, which is kind of crazy because you think, I know I had fat on my tongue. Um, the related conditions that we need to think about are sleep apnea, hypertension, cholesterol. It's not just that they are complications of obesity, but sometimes they are actually drivers of obesity or the result of the metabolic dysfunction. So again, kind of thinking about a car going along that road of metabolic dysfunction, they're like, come on in. We always think, oh, it's because you gained this weight that this happened, but actually it's the metabolic dysfunction. We really need to screen for metabolic disorders in a different way, and recognize that there's limitations to the current guidelines and methods. Like I said, the A1C is just one of many tools, but unfortunately insurers like it. These things called CGMs, I've given a picture right there, are actually way more useful because they give you real-time data on your blood sugar. So if you have something like reactive hypoglycemia, which is a major sort of precursor to diabetes type 2 and an indicator that you have insulin dysfunction and metabolic dysfunction, it'll catch it on a CGM, but that would not be caught on an A1C until things get really far gone, because you might eat something like a big bowl of pasta, blood sugar spikes to 220, and then it plummets immediately because your pancreas overreacts, plummets immediately into the 50s. You feel like crud, take a nap, wake up, and then you're normal again. And so because of the way A1Cs work, that might average out to make you look like you're totally normal if you only have a few of those a month. So the people that have that kind of issue, they tend to present like they get real tired in the afternoon. So tired, they get home, they mean to cook dinner for their family, but then they end up eating a sleeve of saltines and going to bed and then ordering DoorDash, you know? These are people that tend to get hangry. They're like the definition of, that Snickers commercial with Mr. T. That's that presentation. And a lot of times too, you're suddenly so hungry and you eat a bunch of gummy bears, and what you don't realize, because we don't feel the highs, we don't feel sugar highs as much as, like, in the 80s we had the Twinkie defense and all this stuff. That's not real. You feel the lows, but for some people lows can look like mood swings. For some people they can look like, I need to go take a nap. For some people they just feel like brain fog. And so you might not necessarily think, well, that handful of gummy bears that I ate is causing this thing 45 minutes later. Also, using obesity medicine specialists is really important because a lot of people don't have as much time to dedicate to this as I have, in my life. And so they still just recommend lifestyle changes as the first line for severe obesity. They don't understand, like, sort of the underpinnings of it. I mean, this is all that I do. And so people that work in the field, this is like our favorite thing. And it is a really complicated disorder that has really just been relegated to the side and not considered complicated. And we need to treat it like a chronic disease, which means it requires lifelong commitment and possibly medication. And also, like I said, consider other medications that might be driving it. So again, looking at somebody and saying, wait a second, do you need to be on this medication? Are you on this mood stabilizer? Could you take Lamictal instead, or this antidepressant, but is there something else? So what can you do personally? Understand that your genetics are not in your control. You can get mad at your parents, that's fine, but they're not in your control. And also understand that your environment isn't entirely in your control either. How you choose to interact with your environment and behavior is somewhat in your control, but not entirely. Again, sometimes finances can play a role, sometimes how much you're working. So consider your lifestyle, but not your ideal weight, and aim for that. Think about, what are the things that you enjoy doing? What are the things you want to be doing? What are the things that you value? And I want you to aim for that, not just choose an arbitrary weight and go, I want to be 120 pounds because that's what I was when I got married. I want you to think more about, I don't want to go out for brunch with the girls on Sunday anymore. I want to go out for a hike on Sunday. I want to be that person. I want to be the kind of person who gets up in the morning and works out before I go to work. I want to be the kind of person who takes snacks, fresh snacks with me to work. I want to be that person. That to me seems like the lifestyle I want. And I also want to be the person that goes and enjoys a gelato with my kids, that it's okay to have all those things. Your ideal weight will shake out from that. And again, seek comprehensive treatment. Lifestyle means the whole thing, and sometimes we need a whole team to help that happen. And do not fall for snake oil salesmen. This is a huge industry. Weight makes us feel desperate. Again, we go back to those thinking processes of failure. Why didn't I do this? What's wrong with me? Here's this magical potion that you can secretly buy in secret. And you think, oh, okay, I'll do that instead. Understand that also what works for you or what works for someone else isn't going to work for somebody else. It is a wildly personal thing. And that's really why diet books tend to fail, because that diet book might be good for that person that wrote it. I'd like to think that. I'd like to think that they're not just trying to be cynical and make money, but they probably are. But that person has a different lifestyle to you and different taste. What can we all do as a society? We need to really work to end weight stigma. And it can be really hard when fitness is so valued. But things like talking to your HR coverage is something really you can do. There's a website, if you Google OAC obesity, you can find it. And they actually have letters and forms that you can take to your HR and be like, hey, I think it's important that we have this coverage. Also, talk about obesity as a medical condition, not a moral failing. And be mindful of the blurry lines, like the body positivity, healthy lifestyle, and how that can lead to orthorexia. And I am going to shame a celebrity here. I think Gwyneth Paltrow is a great example of that. You know, she likes to present her lifestyle brand as this healthy thing. But then when you hear her talk about what she eats, it's like a cup of coffee and a bowl of broth and a Brussels sprout later in the day. What? That is not healthy. And you can, it's not, anorexia is different to orthorexia. Orthorexia is when you have, like, you take a healthy lifestyle esque and turn it into an eating disorder itself. And a lot of the people that we venerate and hold up in society have orthorexia. And be aware of that. And again, like with that body positivity movement, until I see Steve Buscemi walking down, you know, for Dolce and Gabbana, like it's not there. We're not there. Versus a healthy lifestyle. I know that someone can be living a healthy lifestyle and they don't have to look a certain way. And also finally demand more from our politicians in terms of getting these drug companies to get prices down. We subsidize the entire world. It doesn't have to be like that. And also things like covering bariatric surgery, covering bariatric medication, not cutting Medicare and Medicaid. And a call to action. So really, I want you to think about that. Start treating obesity like a chronic condition. It's lifelong. We don't have a way to fix the metabolism apart from surgeries for certain people. It requires lifelong treatment. That means surgery for some. It means not stopping medications when someone reaches goal or stable weight, because that's something else that happens. When you reach your goal blood pressure, they don't take your lisinopril away, but when you reach your goal weight, they will take your Zepbound away. We have to emphasize prevention as well. Again, that's that demanding more from our politicians, getting rid of these weird subsidies for corn, you know, and then when we can't export our soybean to China, not saying, well, what can we stuff soybeans into, you know, but actually having a food policy that reflects what Americans need in terms of health. And if you have a high genetic propensity for obesity and metabolic disturbances, your kids probably do too. And a family approach is really going to work best. Like I said, I think there's that shame and that sort of, I need to deal with this myself. If you struggle with obesity and your family does, unless the help of a dietitian who is an expert in that so that you can help your whole family without, you know, obsessing or putting an eating disorder onto your kids. Avoid ultra processed foods and move your body, integrate it into your lifestyle and do it in a way that's fun. I have so many people that go, I should be doing cardio. And I'm like, do you like it? No. What do you like? Weightlifting. Then do weightlifting. Like do something you like and do it all the time. And two things real quick, that family approach. If you are concerned, you're like, I struggle with weight. I'm really careful about what I say in front of my kids. I don't want my kids to get an eating disorder because of me. One of the most protective factors against kids developing eating disorders is eating together as a family and eating home cooked meals, period. Point blank. There's not a recipe for it. It is just home cooked meals. It doesn't matter what they are. And also eating together as a family. And of course, avoiding high ultra processed foods is also just overall going to help with obesity. But if you can take that time to eat together, and I don't care if you sit down at the table, I don't care if you do it in your living room, but make a home cooked meal and eat it together, you're going to do more good than any harm that you can do by watching what you eat or whatever it is that you said, you know, saying some stupid thing and being like, oh, I shouldn't have said that in front of my kid. Thank you very much. This is my details. There's our phone number. There's my email if you have anything. I also have a TikTok that I occasionally post on. And that's